We are live now. Fine, everything okay?
Yes, ma'am. Start.
So we'll just wait for a moment because let everyone join and then we will start.
ग्रुप में डाल दूँ
वो डाल रही है रोशनी। इसमें देख रही थी। Let people join. Hello everyone, welcome to our YouTube live session that is for the core surgical modules part 3, and it's going to be a very important session, risk management in postoperative pulmonary embolism. So this is basically a very important topic, and see who is presenting, our own alumni and the course mentor, Dr. Sulekha Yadav. Welcome to our YouTube live session that is for the core surgical modules part 3, and it's going to be a very important session, risk management. So basically Dr. Sulekha is with us today and she will be presenting this very important topic. And let me tell you, she scored 80% in her part 3 exam, so you are going to get a real good advice and a rocking session from her. And she's our past alumni and today our supporting course mentor. So here I welcome Dr. Sulekha. So please, Dr. Sulekha, take over the session. And we also have Dr. Kirtika with us, who will be playing the role and doing the station for everyone. And that's here we go. Yeah, Dr. Sulekha, please.
Yeah. So first of all, I would like to thank you, Dr. Bhavna ma'am, because I am with you since part 2, and I'm really overwhelmed that you are my mentor and you have given me chance to be a mentor. I'm really overwhelmed and thank you for giving me this opportunity.
You deserve it.
A very thank you, ma'am. A very good evening to all of you. And I'm Dr. Sulekha Yadav, as ma'am said. And so today we are going to study about the risk management in postoperative pulmonary embolism. This is a very important topic and it's one of the most common recall which has been asked in the exam because it covers 2 modules, the core surgical and the clinical governance part. So we will be going to study that if a patient develop pulmonary embolism in the post-op, so how we are going to the risk management and how to prevent it's happening in future. So our own candidate, Dr. Kritika Mittal has volunteered to present this test. So first of all, I will give her 2 minutes and then she will present because it's a structured discussion task. So over to you, Dr. Kritika.
Thank you, ma'am.
Candidate instruction. I'm putting 2 minutes. Kritika, fine?
Okay, yes, ma'am. Thank you.
If you want the further information, you can just ask ma'am to scroll the page because there are so many pages.
Okay, ma'am. Ma'am, please next page. Ma'am, next page. Ma'am, next page. Ma'am, any further slides?
Next page is next.
Any further slides?
Yes, ma'am. There. Next slide. Time up. So Kritika, first of all, what have you written in 2 minutes?
First of all, I calculated the summary for the case, and because I will be starting with the SBAR format, so the general summary of the case and just the basic points which I can
One
calculate.
word.
One word for the SBAR format, ma'am. So
Next.
this is a case of
No, I'm just asking what have you written important points in the 2 minutes because our viewers can also learn that how to write 2 minutes. Like you have written
Sure.
uses code, business stable, is part format. How are you going to do
Sure.
the clinical
So I just,
development, risk management, like this?
yes, so like the further SBR format, and after that the risk management, the 4 steps which we do, the headings, and that the particular risk in this patient, and the MEO scoring tables which were given, what is the score, and that the MDT will be involved, and that the further things how will be going on.
Oh, fine. So now you can start. I'm just giving you. Can you summarize this case?
Yes, sure, ma'am. So this is a case of the postoperative pulmonary embolism with a background of a 44-year-old patient who underwent total abdominal hysterectomy, bilateral salpingo-frectomy at least 48 hours ago. And she had risk factors for the venous thromboembolism, being a smoker, BMI 42, and not ambulated after the surgery, and with a missing dose of the Clexane as well, and with the VT risk assessment form not filled out. So my assessment will be based on the history taking for the patient, for the specific preoperative, intraoperative, and the postoperative management. How was it done? And accordingly, I will be recommending to take the management and the multidisciplinary team of doctors and the further plan.
So what additional information you will need in this case for the risk identification?
Yes, ma'am. So first of all, the additional information required from the patient in the pre-operative setting is to ask whether the patient has any personal or any family history of the thrombosis, because that will make her predisposed to the having venous thromboembolic incidents. If she was on any medications like the combined oral contraceptive pills or the tranexamic acid that we can be assessing here. And the specific whether adequate hydration was maintained preoperatively, when was she admitted before the surgery, whether any medications like low molecular weight heparin, any of these things were used or not. In the intraoperative considerations, I will like to know through her case notes about the complexity of the surgery, since this was done for the atypical hyperplasia. So this is a pre-malignant condition. So I would like to know what was the complexity of the surgery, the risk of the bleeding, the type of the anesthesia the patient underwent, were there any dead compression stockings or anything of that was used or not, was adequate hydration maintained during the OT or not. Then the same thing in the post-operative period, since it is written here that the risk assessment forms were not filled out, I would like to know why that was not done, and the reason for missing dose of the Clexane, whether there's an inadequate supply of that, and whether the storage problems were there, or the staff did not knew how to properly access this, all of these things, and why the compression stockings were not made available after the OT, and her general recovery after the operation. When did she start moving about? Were there any catheters, drains, or any vaginal packs which stopped her mobility? Because it is written that she had pain also on the third day, which she had to take the painkillers for. So I will be inquiring about that as well. Was she encouraged to move or not? All of these things, ma'am.
Now, how are you going to do the risk management of this person?
Yes, so ma'am, first of all, the risk management is a separate team in the project management team, so which deals with not only identifying and mitigating the risk, but also to increase the patient's quality of care as a whole. So usually it involves 4 steps, including the risk identification, then the risk analysis, the assessment of the risk basically, then we can do the risk control or the risk management, and then finally the monitoring. So the first step includes the risk identification. So in this context, we have identified that the risk is developing a venous thromboembolic episodes after a post-operative case. And then we have to do the analysis for this. So for the identification and the analysis, we have 2 models with us, that is a fishbone analysis and the failure mode and the effective analysis model. So they are there to identify the contributing factors. In the FMEA model, we break the process into multiple steps. Then we identify every step in detail. What were the contributory factors that led to this particular thing from happening? What were the contributory causes for this thing to happening? What were the likelihood of the occurrence of that? What is the impact of the severity if it does happen, and how can we prevent and mitigate those things in the future? What is the seriousness of the impact happening? Were there any factors related to this thing happening? So all of these things we'll be judging. We have to basically prioritize a risk on the basis of their risk impact. The ones which are more severe have to be paid attention first. Then in the fishbone analysis, we go with the root cause analysis. So there are basically 6 things which can ultimately cause a particular effect to happen. For example, the problems in the patient-related factors or in the process, the problems in the materials or in the management, the problems in the equipment or the environmental problems. So as of now, this patient-related factors were there, that she is a 44-year-old undergoing a major surgery with a high BMI, and also a smoker. So these are the personal-related factors for having the venous thromboembolism. After that, the environmental related factors were there, that the staff was particularly maybe not equipped enough to manage this time of the cases because the risk assessment forms were not filled out. The equipment related factors could be for missing the Clexane dose on day 2 and day 3. So were there any problems in getting the Clexane supply, any problems in the storage of the Clexane injections, and were the staff not properly trained in how to apply these things, how to identify that the patient is going to develop pulmonary embolism, and also for the mobility of the patient that was not quite adequate after the surgery, that also has to be assessed. Were there not enough staff to encourage into how to do this? Accordingly, we have to identify the particular causes causing all of these symptoms so that we can identify any training gaps.
Okay, and then how are you going to do the risk analysis? Besides the analysis you did with the fishbone, any other methods by which you will do the risk analysis, and then how are you going to manage this case?
For the risk analysis, there are other methods like the Swiss cheese model, ma'am. We can go ahead with that. This is to identify any contributory factors causing this whole, whether there's any problem in the technical staff or in the support systems or any patient related factors causing the final outcome to happen. So we can focus on the each and every steps, any training gaps in the staffs involved in this, any communication delays, all of that can be identified. And the equipment related factors, the environment related factors, were the staff already overloaded and high. Yes, ma'am,
Yeah,
and
that
highly.
one you told it in Swiss cheese model, how will you going to mitigate this risk?
Within the Swiss cheese model, we can identify the contributory factors causing this, and accordingly, we can work on those contributory factors to finally manage this thing. So this is a model which helps us to analyze the risk in a particular and critical state and to accordingly work on those factors. Suppose we have identified that the staff is not properly trained, so we can conduct the drills for them. And first of all, for these cases, we have to go with an DATEX incident reporting, so that risk management process. From here, the process will actually start the risk management process. Then after that, we have to go ahead with the documentation on everything. What medications the patient was being given after the OT, how was the pain managed, how was the mobility after the OT, why was the Clexin actually missed. We have to identify why the risk assessment forms of the VT were not filled adequately after the surgery. The drills have to be there for the staff. For all of those who can manage these particular situations, we have to conduct the training session so that they know how to identify the risk factors and to manage also these cases in the future. And then finally, after getting the patient stable, the patient discharge plan has to be made. The patient has to be made aware of the red flag signs in such cases. The GP can also be involved in the further management of the patient if required. So these things can also be done. If effective communication have to be there between the different health team members.
So now this patient has developed like pulmonary embolism, and now how are you going to give how are you going to discharge her? What are the advices you are going to give her on the discharge?
So on the discharge, the low molecular weight heparin, they have to be first continued anticoagulant for the 3 to 6 months period. The patient has to be, first of all, in the multidisciplinary team follow-up. It has to be shared care between the gynecology and the consultant hematologist. We can have the community nurses to look after her, and the special bins we have to give for the disposal of the needles. She should be advised how to take these injections at home, and she has to be well supported in that. The GP specifically has to be involved for the post-discharge care, or aftercare letter has to be written to the GP about the complications that we faced at the time of the operation, so that the GP can be well notified about how to handle such cases. And regarding the suture, regarding the wound monitoring, that can also be managed by the community nurses to help take care of that. And the patient has to be made aware of the red flag signs associated with this thing. For example, if the condition reoccurs and there is any chest pain or any breathlessness, heaviness in the legs, she has to be made aware to return to the contact numbers as soon as possible.
Okay, and how are you going to avoid this happening in future?
To avoid these things happening in future, once we identify the risk for these things happening, so we can fill the risk management team can be taken into account, and the risk assessment has to be done in every patient before the OT, and that should be strictly followed. All the juniors and all the staff, they have to be made aware of identifying the risk. We could have followed the enhanced recovery pathway and made her less days of the hospital admission, more and more ambulation after the surgery. To manage that is very important, and appropriate support, identifying the patients who are at risk of developing this venous thromboembolic episode, and managing this with giving low molecular weight heparins adequately before and after the surgery also. All of these things can be done.
Anything else you would like to add?
For the risk management, we should always go ahead with the radical framework also. That includes with the raise awareness about such cases, then collect and analyze the data, learn from these incidents, and involve the users as well, and making a design plan for the safety. So for raising the awareness, we have the sessions for the appraisal and accountability. We should have the communication between the different team members who are there to support. The design plan have to be made for the safety. Appropriate handover debriefing sessions have to be there. The debriefing sessions for the patients and the family, and also for the staff who have undergone through this particular complicated case, they have to be supported. The feedback should be provided to them in a non-punitive manner. It is important to be hard on the issues but soft on the people. So we have to take care of that.
Overall, you did a very good job. So well done, Kritika. Now I will be giving the feedback.
Yes, ma'am.
So in this case, would you like to discuss whole the case, then the feedback in the end, or feedback first, then do the discussion?
I think it's fine.
Feedback first.
Anything is fine.
Okay. So actually in the feedback, we have to do the communication with colleague. So you have to give a concise summary in S-bar form. So this time S-bar form, S-bar form was good. Communication with examiner in technical language and responding positively. You were responding, you were leading the discussion with minimal prompts. So I think you can just in future, Like you can do the discussion on your own. Once if you know everything, then you should start telling unless the examiner interrupts and asks you the question. Okay. Otherwise you were responding positively. Even I was giving you hint. I was asking because that question was important. So that's why I was asking and interrupting you to ask the question so that you could cover the points.
And we
Then
should not
more like
ideally wait for the examiner. Sorry, ma'am. We
like
should not ideally wait.
like in the Swiss cheese model, I asked you because in the Swiss cheese model, like Swiss cheese, there is whole, like we see in the discussion. So we have to cover that hole or the weaknesses by involving stakeholders at each steps. That is the marking points at all level of staffs who are taking care of the patients, like nurse, staffs, OT, theater team, everyone. And refer to SBAR tool as a form of communication. I think you told this to improve the communication between the team members. Like if the there is taking over, like if the nurse is at 8 o'clock and she's taking over and her duty is off at 8:30 and she has not taken proper over. So that can also be for that. That's why she did not give the examination that injection Claxin. Because she received therapeutic dose, but thereafter she did not receive any dose. So there may be. So you have to improve the communication by the SBAR tool. Okay.
Okay.
Then refer to provided information in the candidate instruction. You use this to identify the possible risk. Apply the principles of leadership in the Swiss cheese model. That is failure point, like stakeholders, clinical, technical staffs and training. You told, but you can just tell in one go. You have to name like stakeholders. In the applied clinical knowledge, you have to identify the risk element. You told everything. Patient factors, method factors, equipments. Okay. And
Yes,
staff.
okay,
You told everything. This fishbone diagram reflecting on patient factors, method factors, equipments, and manpower factors. Then enumerate risk management step. You told risk identification, risk analysis, risk treatment, and the risk control. You told the radical framework. Then identify the modes of failure in the system and the steps for analysis, and that is FEMIA model. You told in the beginning. Then protocol of low molecular weight heparin, because if any patient who has the VT risk assessment done, so they should receive the prophylactic low molecular weight heparin because it reduces the development of pulmonary embolism by 60 to 70% of the embolic episode and continue for 3 to 6 months, you told. But this point is also very important, like 60 to 70%. If the patient is high risk, we should give her because it will prevent 60 to 70%. That is important point in the blood clinical.
Okay. Percentage also. Okay.
And in the patient safety, recognize risk factors that contribute, you told, like smoking, age, BMI, pelvic, post-op care, no ambulation, missed flags, and intra-op and the post-op, like hydration status, you told. Okay. See problems in the barrier, the problem in communication and the documentation, discharge criteria and follow-up plan. You were not telling, so that's why I asked, because that is marking fine.
From the red flag sign and symptoms, you are telling?
Yes, red flag signs and symptoms you told.
Okay.
Okay, now we will study. Ma'am, can you change the slide? So in the summary, like you can say that, like in this case, this patient is a case of a post-operative pulmonary embolism, right? So situation is post-operative pulmonary embolism. Background is, you will tell everything because she is a 44-year-old. She has uneventful subtotal abdominal hysterectomy and bilateral subepigmenectomy for atypical innovative hyperplasia with heavy menstrual bleeding. Okay. She is a case of smoker, BMI of 42. And she developed pulmonary embolism on third day. Because you gave in candidate instruction in the operative notes that she was managed by the therapeutic anticoagulation in ICU and now she is stable and planned for discharge. So now she is planned for discharge, so you will do the assessment. In the assessment, you need more information, like why it happened to the patient, and you will confirm that is the patient fit for discharge. And then you will make a recommendation that the plan of follow-up under MDT care and plan of risk management to avoid the risk complications in the future. Okay.
Yeah, I
please,
think
ma'am.
this SBAR is perfectly done. Just would like to add one point here that this situation, this usually people, what they do is they just keep on reading the same thing from their station, the complete scenario from the station, which is the biggest mistake, right? So we should be able to make a proper diagnosis over it and then make the situation. Yes, please continue. Nice.
They get irritated. If
Yeah,
you are
that's very irritating. You lose marks there because many people, they in situation, they just open up the station and start reading from there.
and
That's the
SBAR carry borderline marks of
The
failure.
general tendency. Yes, yes, ma'am. We should take care of that.
And so you will ask the additional information because in the assessment you planned like I have to ask the additional information. So in the additional information, you will review her notes like pre-operative and the post-operative. This is very important. Then you will rule out has the any thrombophilias because thrombophilia also lead to the thrombosis. Then other medical conditions before surgery like Vasions, oral contraceptive pills or tranix semic acid. If she has any past or family history of thrombosis, type of anesthesia and duration of anesthesia as well. The use of stockings and the pneumatic compression, pre and post-operative hydration and ambulation. If she had primary and secondary assessment of a VT, because you see in the candidate instruction, her VT assessment risk was not filled. It was
Yes,
empty.
ma'am.
So, and reason for mixing Clexane dose after giving the first dose. If the patient was diagnosed and he has received, then why the dose was missed? Then examination that because you are discharging the patient, so you will examine her vital signs. You will see, you will check her abdominal wound, and you will check if it is suitable for discharge. Okay. Then after that, like you will just make the what are the risk factor in this case, ma'am. Next page. So you will just check, enumerate the risk factor in this case. Because you did the SBAR form, you ask the additional information, and then you will make a note of it. What are the risk factor in this patient? Like she is a 44-year-old, she has high BMI, she is a smoker, she has a major surgery, and she has like pre-malignant surgery, like endometrial hyperplasia with atypia. She has missed dose of Clexane, primary and secondary assessment was not done. And there was also in the operative notes written that no ambulation after surgery on the first. So these are the major risk factors. So you will focus on these risk factors as well, like how we are going to do the risk management on this part. Okay, ma'am, next please. Now we will start with the like risk management. So we will just define what is risk management. So risk management is like quality improvement tool, and it is to detect, monitor, and we have to assess and mitigate the risk to the patient. So how we do? It is a set of clinical and administrative system, because in this administration is also involved processes, procedures, and reporting structures. So everyone is involved in this case. So that's how we are going to do the risk management. We will start with the steps. What are the steps of risk management? So there are 4 steps. We have to first do the risk identification. Okay. So what could go wrong? Risk analysis. What are the chances of going wrong and what is its impact? Then how we are going to do the risk treatment, how we are going to do the minimize or mitigate this risk. Then at the last, we have to do the risk control, sharing or leading, like it for the future, so that it does not happen in any other patient. If we get the similar patient like this in our clinical settings, then we will start with the risk identification. In the risk identification, we have the FUMIA model, and its full form is like failure mode and effective analysis. How we are going to do. So it has 8 steps. Like, so in this case, we usually examine the process in this detail, like to see what went wrong at each steps. Like the patient was admitted, since her admission, pre-operative and the intraoperative and the postoperative. At each steps, we will see that what went wrong. Then what are the consequences of each failure mode? Okay, then we will identify if there was any underlying cause, was there any contributing factors. Then we will rate each contributing factors or failure mode in terms of its frequency or likelihood of occurrence and severity. Like was it severe, the factors which we missed, or the failure which has happened, or that the wrong, that what went wrong at each step, was it serious? Then existing control to prevent, because in this case that patient was diagnosed on the day 3 and he was shifted to SDU, and it is a near miss event. It's because it's a near miss event in her case. Then we will use the rating to prioritize the risk, which risk to accept and which to reject. And then we make a clear action plan, like what we are going to do in this case. So you have to tell all these things in the exam, like how you're going to do the analysis. You can just write in your own way. You can just memorize in your own way. It doesn't mean that my language is fine. You can just use in your own way. Then we have the fishbone analysis. Like in this case, we see patient factors, individual factors, task factors, communication factors, the team factors, then education and training, equipments and resource, working conditions, like the overworked, are the staffs overworked, organization and strategic factors. So this is general. And now we will discuss about pertaining to this patient, that what were the patient risk factors, what are the method risk factors in this case that was missed, what are the equipment factors, what were the manpower factors. Okay, ma'am, next please. So in this case, patient risk factors, patient was 44-year-old, BMI 42, she's a smoker. She has no ambulation on day post-operative day 1. And we will also check by pre-operative and post-operative notes to check on her hydration status. Okay. Then we will method factors. She has major surgery, she has pelvic surgery, she has pre-malignant condition, duration of surgery, intraoperative bleeding. From her operative notes we will check. Then we will check facilities and equipment factors, because her collection was missed. So missed or not documented. Like she has received the injection and it was not documented in her notes. Was there any wrong storage of medication? Was there any inadequate supply of low molecular weight heparin or stockings? That's why she did not receive the medication, because it happens in the hospital also. VT risk assessment form, why was not filled? Why the risk assessment was not done? Was the patient missed it at the first place? Pneumatic compression was used. Why primary or secondary assessment was not done in this case? Because he is a high-risk patient. Ma'am, next. Then we will check about the manpower. So we will check that was the staff very busy units, was and the staff was overworked. Was there any lack of training on the VT risk assessment and treatment? Was the SWAT tool is used for communication? Communication problem that leads to the missed anticoagulation. Like the patient, the 2 nurses did not communicate well, did not take the over well. That's why they missed that this patient was on Clexane, and so that's why she missed the next dose. So these all are the fishbone analysis. Next, ma'am. Now we will also do the risk analysis, as we did with the fishbone analysis. Then we have the Swiss cheese model. So in the Swiss cheese model, it is used for analysis of major accidents and catastrophic system failures. Like in this case, there must be major accidents. That's why it leads to the near miss events, because this patient developed pulmonary embolism. It would have costed her life if it was not managed in time. So it is used for analysis of major accident and catastrophic system failures, and that may result from small failures, because in this patient small things were missed. So that's why it leads to the actual result, that is pulmonary embolism. So in the Swiss cheese model, it actually helps us to identify was there any weakness in the system, and we can close these weaknesses by involving the stakeholders from all like in the operation theater, in the ward, nurses, doctors, everyone, to close the weaknesses by principle of leadership. Like we will just tell everyone, then clinical and technical support, and we'll do the training of staff for the VT risk assessment, for the SWAT tool, for the communication. Like in this way, by the principle of leadership, clinical, we can just stop these catastrophic events. And it can also avoid the human losses by series of safety barriers or precautions we can take to a particular hazard. Okay, ma'am, next.
Just before going to the next, I would like to clarify here one point. I'm rather asking you that we have talked about three models till now, FEMIA and Swiss cheese and the fishbone, right? So do we have to apply all these models for every risk management, or there is certain, like for any particular thing, this model is correct, something like that?
Ma'am, I think if we are doing the analysis, we should apply because it was a near miss event, so Swiss cheese model will be applied because it is used in the catastrophic events. And the fishbone analysis will also be used because it is applying the patient factors, method factors, equipment. So I think it like all the models will be used in such cases.
Okay. So basically, because this is a near miss, so therefore we are going to use all of these. Otherwise, we would have used fishbone and the FEMIA model. Am I correct?
Yes, ma'am.
Yeah, that should be the message. I just wanted to make clear the message to the viewers. Yes. So this is the Swiss cheese, as we can see the multiple holes. Yes, continue, please.
So this is a Swiss cheese model. Like there is hazards, risk, and there are engineering controls where we can just stop. If there is hazard, we can just mitigate this control. But if there are holes and this is passing through, then if it is missed at each steps, then it will lead to the actual hazard. That is a small failures at each steps. So we can just control by engineering control, administrative controls, like I told, the leadership, communication, stakeholders, involving the stakeholders, behavioral control, like we can just improve the communication, we can be alert and like conscious, like we are giving this injections to this patient. If the patient is getting sick, we are making note of their vitals and everything, like we do in the hospital settings. So in this way we can just stop. But if it is missed at each steps, then it will lead to the actual like catastrophic failures. Like in this case, that missing klaxon, her BT risk assessment was not done. Like these all are the small risk factors. Ambulation was not done. So that's why it leads to the pulmonary embolism.
Yeah. So if I need to summarize, then FEMIA model is a proactive, right? We are going to look actively into the further that what can go wrong. So it is more about identification. Then we come to the fishbone, which is reactive cause analysis. That is something has happened and we are going to look into multiple causes for that. So that is a kind of reactive. Something has happened and now we are reacting to it. And then Swiss cheese is the system errors, where the already multiple layers of defense are present, but still the system is failing. So we are going to take care of a complete system and going to look at the system per se to find out what is the error. So if just summarize, FEMIA is proactive and your fishbone is reactive and Swiss cheese is system, right? So that would be, I think, 3 lines for 3 models.
Yes.
Please continue.
Now we will start with the risk treatment, because this case patient has developed pulmonary embolism, and now we will start with the clinical governance step. So risk treatment. So we will start by ethics. We will do the incident reporting. We will just cooperate with the facilitate the local investigations within the unit. Then we'll do the documentation chronologically. Okay. In the risk management. Then we will be debriefing this case to the patient, family members, and the team. And all things, all the events has to be explained by the consultant to the patient. Then the duty of condor. In the duty of condor, we explain the chain of events. And even if the patient is angry and like not accepting why this happened, then we have the patient advisory liaison service can be offered. Okay. Then we will start with the discussion with our team members, like our consultant, all whoever who all are involved in her care, because it's a near miss event. So we'll do the discussion by doing audits. We'll do the root cause analysis. And in the root cause analysis, where the risk management team, like you told, the risk managers, stakeholders, And we will collect the data from the medical records. We will interview with the medical team. And then we will do the reflective practice in non-blaming manners to know the shortcomings and the contributing factors. And then we will do the re-audit after 6 months after discussion. Then we will make a plan or the protocols that how we can avoid such catastrophics on the near-miss events in future.
And it's very important to note that the debriefing should be done by the consultant, right? So that's a very, very important point to highlight on. Yes, please.
Now that which the results has came, results has to be evaluated and we have to share in the meeting like we do in the audits. Then gathered and then agree on the re-audit after 6 months, and then we will do the drills. In the drills, we can just stitch all our staffs, technical staffs and the clinical staffs about the VT risk assessment and the VT risk assessment to fill the VT risk assessment form, improve the communication by the SWAR for the quality care. And then we will make a discharge care plan and we'll give the red flag signs to the patient. And in the red flag signs, we will tell the patients signs to seek the urgent help, like she told, the signs in terms of shortness of breath, pedal edema, and if she has breathlessness in this chest pain, then she will come to hospital. Emergency contact numbers will be given, and she will be come in contact with the MDT team, where the consultant, hematologist, GP, everyone will be involved, and she will be continued on the anticoagulation at least for a period of 3 to 6 months. And then she will also receive the adequate support and the contact and the psychological support as well, counselors as well. Now, how we can just control that it won't happen in future. So in that case, we will do the by the radical framework. In the radical framework, we can just raise the situational awareness that if the patient is like we can raise situational awareness to the patients, to the staffs, and to the like everyone, to our own colleagues as well, that if any patient coming with the high risk factors like high BMI, major surgery, pre-malignant surgery, so we will just to improve the SWAR communication, VT risk assessment will be done, the primary and secondary pneumatic compressions. So these all we will take care of so that it won't happen. Then we will do the design for safety stakeholders like SWAR and the care bundle. Then we will collect and analyze the data as we did in the audits or the root cause analysis. Then we will learn from the incidents. We will involve the users as well. And then in these patients, we will make a discharge care plan. And in future, if any patient who is on OCP or HRT, we will just make a plan that we should avoid OCP and HRT. And any further surgery, we will just try to be minimal invasive surgery with the implementation of enhanced recovery program to avoid development of pulmonary embolism. And the pre-operative, we will do the VT risk assessment and we'll ask the patient to reduce her weight before going for the surgery. And we will advise her early ambulation. And we will also tell that if she is a high-risk patient, then she will receive prophylactic low molecular weight heparin. So because it reduces embolic episodes by 60 to 70%. And then in the end, we will just do the proper handover, documentation and communication by involving our seniors, consultant, and the protocols for reviewing the prescribed medication with the WHO surgical safety checklist. So that's how we can prevent in future. So this is the radical framework flowchart. You can just read like raise awareness, promote awareness and understanding of patient safety, engage clinicians, training, education, teamwork, risk management forums, communication strategy, appraisals, accountability, safety leadership at board level. And then we, for the design of safety like a standardization by following the guidelines, the protocols, SWAR form, like we studied. And then recommendation, we will involve the care bundles, handover, debriefing, and the surgical safety checklist, like we discussed. And in the collect and analyze, like we will safety climate measurement, proactive and pre-operative risk assessment, incident reporting, and the case notes review, root cause analysis. These all are the same as we discussed. So that's how we are going to do the risk management of a near-miss event, that's pulmonary embolism. And in the end, we have to learn from such incidents so that it won't happen in future as well. Like from the feedback, risk analysis, safety, audits. So Kritika, fine?
Yes, thank you, ma'am.
Clear?
Thank you. Yes, ma'am. Yes.
Because
Sure,
if
clear.
in the exam, anything, if it is asked, we have to stick to that only because they want to hear that only. If you talk in general, they won't give you marks.
I'm
Because
also
they have,
deep.
because
Sorry,
they
ma'am.
have marking sheets and they are just focused on the, like their laptop and they are just sticking. Everything is written in the marking point. Has he told MDT? Has he told S bar? Has he told, like they will tick like this.
Okay.
Yes,
Ma'am, debriefing.
yeah. So would you just tell about what are the failure points for this particular task so that everybody comes to know that at least this part has to be done?
So my failure point is the S bar form and that switches model that were involving the MDT stakeholders. Stakeholders is the very point, the definition of risk management, the risk identification, 4 steps. This is borderline. And then apply the principle of leadership, including stakeholders, clinical, technical, and training of staff. This is also borderline point.
Mm-hmm. So because that's, if somebody knows that and he's at least they can cover those and clear the station. That's the point here. Yes, Dr. Ketika, your question, please.
No, ma'am, I was just asking the debriefing has to be done by consultant only.
Mm-hmm. Yeah,
No,
usually
you will
either
tell
the
that
yeah.
debriefing will be done, but ideally it should be done by the consultant.
Okay.
Because we are ST5. They won't listen to us. Because in India,
It should be done by a consultant, but still any senior person who is involved in that incident can do that, but not the midwife or some theater staff or not like that, right?
Yes.
Okay, would you like to go through these points for the point-wise, domain-wise
Next
feedback?
one, only 2 slides are there now.
Mm-hmm.
I will discuss about the patient communication with colleague, patient safety, and applied clinical knowledge.
Right. So these are the points for the communication with the colleague where you have mentioned about the SBR and using the technical language, leading the discussion involving MGT and stakeholders, which I've already told, SBR tool, and this all. This coming to applied knowledge.
Yes, ma'am. Fishbone diagram and the patient method. This is very important. Risk management steps, it's also failure point. FEMIA model, the types and modes of failure in the system. And the protocol of low molecular weight as prophylactic and prevent 70. This is borderline point. So that's why I was giving you hint that what are you going to give her a discharge care plan? Because in the examiner, if it carries marks, they give hint once, but not twice.
Ma'am, I told that low molecular weight can be continued for 3 to 6 months.
Yeah, 3 to
but
6 months, but you have to tell also that 60 to 70% it will reduces the body capsule.
Okay. Okay.
And in the patient safety, these all are covering in all the domain, like risk factor, smoking, age, BMI, post-op, missed exons. Like we told in the water, the risk factor in this case. Then asking her to review notes. This is also the borderline point. And the C barriers in the problem in communication document, that is switches model. And discharge criteria and the follow-up plan and the red flag signs will also be.
Yes, so these will be your domain-wise feedbacks, and yes, perfectly done. Good. So overall, this was a very good discussion. We could learn the steps of risk management, the various models which are applied in the risk management for identification, analysis, and then finally risk treatment as well. When we talked about the radical model, so it is important to know these names and a bit about in details about these models as well. Although seems confusing, but actually they are easy. If you try to understand them, what exactly they are doing, then it becomes very, very easy. So nicely presented. Dr. Kritika, do you have any more questions?
No, ma'am, that is fine. Very nice session, really. Thank you, ma'am.
Okay. Okay, so we could
You
learn.
did very well, Kritika.
And
But
Dr.
you can
Sulekha,
perfect it to get more score.
yeah.
Thank you, ma'am.
Dr. Sulekha, can you put up two lines for what they can do to bring their marks to 80%?
Yes, ma'am. So first of all, I would like to perseverance, consistency, and the willpower that I have to I was just studying so that I can pass. I was not aiming for 80%. I was like, I don't want to go through this module twice. It's enough because it's very demanding course. And I think what helped me that after I gave mock to Dr. Bhavna ma'am, she told me my flaws, and after that she advised us you can do mock with your role player. Like I started doing mock in April. Like I gave mock to ma'am on 13th April, and from 14th April I was doing mock with with my partner, and we used to do 7 to 8 tasks a day. And in the end, I was doing 20 tasks and 22 tasks daily. So that helped me a lot. That helped me to mitigate my fear of exam. And in this exam, everything should be in your subconscious mind. You don't have to think like you were thinking what to tell next. No, it should be in your mouth. You are telling on your own everything. You are not giving chance to the examiner, and you have to act as well. Like the first case I got urethral diverticulum, but it was not written urethral diverticulum. It was written she has some vaginal cyst, and she had the patient has dyspnea. She has difficulty in sitting, and she has excessive pain, and she was uncomfortable. Sometimes she was on the chair. She was very uncomfortable to talk. So you have to focus on the role player. When you go to the examination center and there is examiner, just see that they don't exist. You and your role player, like in your clinic, and you have to focus on the role player and her concerns. If she is uncomfortable, you have to address that. Like, I can see that you are really uncomfortable. How may I help you? In this way, you have to act because she is also acting. She has no any urethral diverticulum, but she is acting. So you have to act as well in this case. And when I saw the case, I was like, vaginal cyst, I was confused. I was in the subconscious mind, I was thinking of urethral diverticulum, but it was not clearly written. So I put that all the cases, I asked every question. Then she started giving me hints on her own. When I covered all the information gathering, she told me I have dyspnea as well. I have dribbling of urine as well. Because I was giving her the differentials of urethral diverticulum. Then she started giving me hint. And even in the exam, she will ask if you have told her everything, still she will ask you as if she has not listened. So you have to address her calmly. Even if she is asking you twice, thrice, you have to address her. And you have to practice, practice. Like it is in your subconscious mind, and you are just, even if you have not studied the station, it should be running in your mind, and you're going to tell that station only. Because it was in the exam, even I got evolving kidney injury. I did not tell a word of evolving kidney injury because I got confused. When I started differentials, ma'am told there is no sepsis. I was confused because when the examiner interrupt you, you just lost your momentum. I was like, there is no sepsis. Then it started, she was telling me, then I asked her, ma'am, why CS fever? Then why it's written that CS fever? Then she was telling me, maybe that junior has mistaken. Then I then I have to tell, I told everything. Like if this case is developed, this case, because she was twin pregnancy, she has gestational hypertension, she was not on any antihypertensive. So she has blood loss. So I was telling everything related to that station only, but I did not utter a word of evolving kidney injury. See that how are you going to manage this case? So I told everything like avoid potassium rich diet, MDT, call for help, everything I told, documentation, vital charting. So like in this, so you have to practice in such a way that even if you're telling from your subconscious mind, it should be that case only. You're not making mistakes. You
Yes,
don't
it is
new
actually like driving. When you start driving, you have to see, and then once you are on the road, then you can have your coffee, your music, everything together. So part three is like that only. You should be so much prepared that when you go to the station, you are just telling, you are just doing it
and
subconscious.
even if you saw the new station, like I gave you all the post surgical and everyone was scared. Don't get scared. Even I did not know, but I studied, I memorized, even I had difficulty in memorizing. So I used to write in my own way, like in my own language. Because uh, unless you write everything in your own language and you tell to the examiner in your language, then you will be able to like spontaneous. It will come out of your mouth. And for this only you have to practice with your role play. Practice is very important. Even I got shoulder dystocia, even if you are teaching the station, like you have to be very confident, like because they see in the UK they see the confidence knowledge, like how you are able to convince the role player, how you're going like how confident you are, like you are safe doctor. So confidence is very important. Because in November I gave and I was not confident. I was covering all the station, but I was not confident. I was my volume, because when you are not confident, you will speak low, your volume will be low. So they don't listen. They just get bored. So they will not give you marks. Because you have to be very short, concise, and confident
Mm-hmm.
for all the
Now,
cases.
when it is just 2 months before the exam, what should be the strategy?
So anything else you would like to ask, Kritika? Because for me it was practice, practice, and practice. And even I was crying when I got 80% because I just wanted that I should pass this exam. But I got 80%.
So for last 2 months, what all they should do?
Mock. Mock, as ma'am has said, that helped me a lot. Mock. Do mock, because that way you will be able to cover the syllabus, cover the modules. Because if you're doing 7, 8 tasks, 9 tasks with your role player, then 7 your role player, 7 you are covering 14 tasks. Okay. And in the last 1 month, you can just cover 14 tasks. You can just give, if you are not able to do 14, at least 10. So if you are giving 10 like 10 mock to your role player, 10, she will give 10 mock to your role player, like different tasks. That way you will be able to cover 20 tasks. So that way you will revise again and again, at least 5, 6 times you will be able to revise.
Hmm.
And
And it's not
that
about
way you will be,
every time you go and finding new tasks. It is more about learning your original basic tasks because they do help,
yes,
right?
same task. And never get disheartened with new tasks, that this is very new, I don't know anything. Even if you don't know anything, just do in the structure discussion, start with S bar, and in the like information gathering, like in the SPT, start with information gathering. Because with your MBBS knowledge, still you will be able to just crack it. Because in the exam I got adenomyosis, it was new task. Even I was explaining the adenomyosis wrong to my role player. I was explaining fibroid. Then she told me herself, I think I read about in the internet that this is some endometriosis. Then I was on track. I remembered everything from my MBBS. Like PG.
Yeah, it is actually like I see people panicking a lot. Why new station? Why this is in practice station? But it should not be. Because when you go to clinic, you are prepared for any patient. You don't know what patients you are going to see today in your clinic. Then why this one? So we should be ready to take up all that. Yes, perfect.
A mock
So
is very important. Like you can take mock or you can just do mock with your role player. That will be better.
say
And you
take
can just
mock,
give
how
feedback.
much you are going to take mock? That would be only a one-time experience. So better is like you take 1 or 2 mocks and take the overview from the mentor, and then daily practice cannot replace that. Daily practice is daily practice.
You can just practice with your role player and you can give feedback. Like you were not empathetic, you were not sensitive, and your this was not there. Like important points, you could just tell. Be more critic. Be more critic.
1, 2
It's
mocks are certainly very important and they should be done. But after that, daily practice is the must thing to
daily
do.
practice is very important.
Okay, so thank you, Dr. Sulekha, and thank you, Dr. Kirtika, for being here. And we really enjoyed the session. And this was one of the most important sessions. And if they get an exam, they'll be remembering your words. So I think that would be quite helpful. And we'll keep on having more such sessions. Till then, if you are looking for some part 3 course, then I would suggest you can come up with us, because we have success in 70% less study time as they all are here. And definitely something unique, unlimited access till you pass. And you will get a domain wise mark sheets feed for all your tasks, which you can use when you are practicing with your role player to get the exact kind of a feedback, not to wait for anyone. And the crash course for the November exam is already going. We have done 2 sessions, still more to go, and hope to see you all there. Okay, bye bye. Thank you so much. Thank you for
Thank
joining
you,
in.
ma'am. Thank you, Kritika.
Thank you.
Thank you, ma'am.